As we continue our discussion on initiating and adjusting, we need to talk about the inspiratory hold or the inspiratory pause. This is something that we don't use routinely, simply because it has the potential to increase the mean airway pressure and lead to further damage or adverse effects. A brief hold may improve distribution of ventilation and oxygenation. Other uses, which are not routinely used, an inspiratory pause time of 0.5 to 2 seconds to obtain a plateau pressure so that you can calculate compliance and resistance, and also an inspiratory pause for chest x-ray. Again, you can do this with just the inspiratory hold button. You don't have to set a time on there to do that and then forget to take it off. Just use the pause button, the inspiratory hold button, and just do it temporarily. And that way we don't go off and forget to turn the inspiratory hold off. The FiO2, or the oxygen percentage. If you're unsure about what's going on with the patient, you're going to start them at a high FiO2 at 100% and then titrate it rapidly down on clinical progression and saturation. This is many times what we do with our surgical patients for pretty much anyone. Start them off real high and then titrate it rapidly. Previous blood gases, stable patients, diseases, response to oxygen, start on 50 to 70% oxygen. The postoperative or COPD, emphysema, chronic bronchitis, drug overdose without aspiration, or neuromuscular diseases and postoperative patients with normal lungs. Monitor closely, particularly the saturation, and adjust as required. So again, depending on the saturation, and if you have a titrate order, according to a specific saturation, then you have the freedom to adjust that up and down. But because oxygen can be toxic, we don't want to leave it at that high FiO2 unless we just absolutely have to. Even then, if you have to leave the FiO2 high, or if the patient requires a high FiO2, you probably want to start PEEP or CPAP. Now, the new NBRC guidelines say that you don't even have to go to 60% to start adjusting the PEEP or the CPAP. You can start at 50% even. So initially, PEEP of 5 is physiologic, so pretty much everybody gets at least 5. That's what you and I have right now. Higher PEEPs used to improve or maintain the FRC and oxygenation. Of course, that's the way you deal with a shunt. High FiO2s, where the PO2 is 50 to 60, you may consider use of PEEP. And additionally, to treat acute lung injury, ARDS, or pulmonary edema. In high FRC conditions, you may use to offset the auto PEEP and gas trapping. In this case, you want to try to minimize the auto PEEP with the use of PEEP. Ensure that the set PEEP does not go above 80% of the measured auto PEEP. This is figure 44-7 on page 1105. This is airway flow, pressure, and volume in a patient with severe airflow obstruction and auto PEEP. There is a rapid decrease in expiratory flow at the onset of exhalation because of the obstruction. This is at point A. And there's a lack of return to flow to the baseline at the end of the breath at point B. This type of expiratory flow pattern, regardless of the expiratory time, indicates auto PEEP. The amount of auto PEEP cannot be determined from this example, but any time end expiratory flow is greater than 0, auto PEEP is present. Open lung strategies, recruitment maneuvers, and PEEP. In acute lung injury and ARDS patients, you want to start the PEEP at 10 to 15 centimeters of water. And this is important, and we get this on here before the ARDS sets in, so that when the condition occurs, that we already have the PEEP on there and the lungs are already open. So we don't have to open them after the condition is set in. So this 10 to 15 centimeters of PEEP maintains an open lung. For the ventilation, the pressure control to target tidal volume at 4 to 8 milliliters per kilogram of ideal body weight. Now remember, the MBRC is now saying 4 to 6 milliliters per kilogram. In addition, you want to increase the respiratory rate to maintain acceptable PaCO2 and pH levels. And so what you may wind up doing here is permissive hypercapnia, where we're basically turning them into a CO2 retainer with the understanding that we're going to compensate for the pH. And then lung recruitment. This is where we talked about where you increase the PEEP to a significant level of 30 or 40 centimeters of water for a short period of time, like 3 minutes, recruiting the alveoli, and then gradually decreasing the PEEP to maintain the recruitment. If you have the option to set a rise time or slope, this is the time that it takes to reach the peak pressure. That's what this represents. So it's, in some ventilators, it kind of represents part of the waveform. And so typically it needs to be steeper rather than shallow. Alarms must be set tight enough to warn of problems without being a nuisance. For example, the pressure limit and volume control set at 10 to 15 centimeters above the peak pressure. If peak's too high, can remedy by decreasing the peak flow or decreasing the tidal volume, increasing the I time, or changing the flow waveform. See figure 44-12 for a summary of initial settings. That's on page 1107. This is figure 44-8 on page 1106. This is the effects of changing rise time during pressure-targeted breaths for a patient who prefers moderate flow. In section A, the flow exceeds the patient's demand, and a pressure spike and short inspiratory time result. In section B, as flow is decreased, inspiratory time lengthens, and the pressure spike disappears. Machine output matches the patient demand. In section C, when the flow is reduced further, the patient's demand exceeds machine flow, and the result is deformation of the pressure waveform and a decrease in the inspiratory time. So we have the ventilator set up and it's ready to go. And now we're going to attach the patient to the ventilator, and we're going to turn our focus to the patient. Now this may be, there may be no connection here. It may be that you're in the ER and the EMS brings the patient in and you attach them to the ventilator there. Once that patient's on your table, it's your patient. Then you need to do the assessment stuff. If you take over care like in the ICU, then once you receive your report, then it's your patient and you need to do the initial assessment. Or if it's patients, coming from surgery, or if they're just being intubated, initial assessment is still called for. And so this is box 44-13 on page 1107. So now inspection, palpation, and auscultation. Let's look at them and let's see what's going on there. The assessment of the position of the artificial airway in cuff inflation. Assessment of the pulse, blood pressure, oximetry, and electrocardiogram. Inspection of the patient ventilator system, breathing circuit, humidifier, ventilator settings, and findings. Analysis of the arterial blood gas values, and then inspection of the chest x-ray. And of course, anytime you place an endotracheal tube, there's going to be an x-ray done, and then 30 minutes later or so, you're going to do a blood gas. And remember, at that point, we changed to phase 2, and then we're just trying to accomplish good values on the blood gas. So initially, our target saturation is greater than 90, or on the blood gas where you have a PO2 of 60 to 80. Remember the 30, 60, 90 rule? If for some reason that you're not able to accomplish that right away, here's a simple formula to determine the oxygen needs. And again, the healthier the lungs, the more accurate this formula. So when you first set it up, Typically 100% for initial patient settings, titrated in increments of 20 or less. Once the desired PO2 or saturation are reached, then you change to about 5 to 10% increments. Titrate using ABGs or pulse oximetry or both. In evaluating the PEEP, you want to use as little PEEP as possible to accomplish adequate oxygenation. So what we're trying to accomplish here is at least a PaO2 of greater than 60 on an FiO2 of less than 60. So we adjust the PEEP to where we can accomplish this. Optimal PEEP is based on the oxygen delivery, which is the cardiac output times the arterial content. And remember that the arterial content is then PEEP is increased by 2 centimeters of water until the DO2 decreases. Once the best PEEP is exceeded, go back 2 centimeters of water to where you were being successful, and that's your best PEEP. This is table 44-7 on page 1118 of your textbook. This is an example of positive end expiratory pressure study including ventilation, oxygenation, and hemodynamic values. So as we look up and down this table, you'll see over here on the left side, these are the values that we're looking at, that we're concerned with. And then across the top of this table are the different levels of PEEP. So what we're going to do is we're going to evaluate each of these items at each level of PEEP, and we're going to determine the optimum PEEP. So when first reviewing the PEEP study, observe changes in the following things: the airway pressure, the blood pressure, arterial oxygen, whether that's PaO2 or SaO2, and mixed venous oxygenation, oxygen transport. With increases in PEEP, the PaO2 and saturation improve. Airway pressure increases, compliance improves, and then decreases at higher levels of PEEP. And oxygen transport improves and then declines. The optimum PEEP for this patient is 10 centimeters of water because it provides the best arterial oxygenation without decline in oxygen delivery or cardiac output. This is figure 44-16 on page 1117 in your text. This is a static pressure volume curve of a patient with ARDS. The volume is increased in increments of approximately 100 mLs. Inspiratory plateau is measured, and the pressure volume curve is plotted. Straight lines A, B, and C are drawn tangent to the curve, and the lower inflection point and the upper inflection point are identified. PEEP is adjusted to approximately 2 centimeters above the lower inflection point. So the lower inflection point is where you set your PEEP. The upper inflection point is the limit of your tidal volume. So the difference between the two would be the tidal volume that you set. I want to refer you again to the ARDSNet study. But this is that study where they studied the ARDS patients and came up with the FiO2 PEEP relationship. And so this is a good reference to determine which is which and what do you want to do with which ones. That, you know, the higher the FiO2, the higher the PEEP requirement. And so we're trying to accomplish the reasonable PaO2 because we have to oxygenate them, right? We don't necessarily have to ventilate them, but we have to oxygenate them. So we're trying to get a PO2 of 60 to 80 or saturation greater than 90. Other oxygenation techniques: sitting the patient up or getting them out of bed and walking is better. And we're seeing that more and more often these days where we're actually walking the patient on the ventilator. Of course, it's very labor intensive and personnel intensive because we have to have a lot of people there, but it's certainly good for the patient. And in addition, the head of the bed at 30 to 45 degrees of elevation reduces the risk of ventilator-associated pneumonia. In addition, postural drainage and adequate humidification and bronchodilator therapy may be beneficial. Prone positioning may improve the PaO2 and decrease the shunt, may reduce mortality in the severe ARDS patients if used early. Mechanisms may be in ARDS the dorsal lung injury. Supine most gas and blood flow to the dorsal injured areas, so shunt increases. And then if you prone them, most of the gas and blood flow to the dependent areas where healthy lung tissue is better, so ventilation and perfusion have better matching. This, of course, the proning can have serious complications, and so you have to use this cautiously. And again, I want to say from the Essentials textbook, Kazmarek says that this is not a cyclical thing. Once you prone them, you leave them there, and you get better results like that. But in most cases, in practice, what we do is we turn them supine and prone every couple of hours or so. Adjusting the ventilation is determined by the respiratory rate and the tidal volume and the dead space, the physiologic dead space. Of course, the physiologic dead space is the combination of your anatomic dead space and the dead space caused by the disease process. So the alveolar ventilation is equal to the tidal volume minus the physiologic dead space times the respiratory rate. And so that's for 1 minute. The adequacy of the alveolar ventilation is best assessed by the arterial pressure of CO2. If the PaCO2 rises, then alveolar dead space is inadequate and vice versa. And so here is a formula for predicting the PaCO2. Ventilator adjustments to alter the PaCO2. The rate change only with no change in the volume of CO2 production or physiologic dead space. This is where we're going to, once we set the tidal volume to a reasonable volume, then we don't have to change the tidal volume anymore. What we can do is we can adjust the rate to achieve the CO2 that we want. So here's the before and after equation, where they call it initial or desired. But before, the settings and the values you have before, like the CO2 and the respiratory rate, you set that equal to the after. In other words, you choose the CO2 that you want and calculate for the rate. In the event that you only want to change the tidal volume, if, for example, they don't have an adequate tidal volume, or maybe you want to increase it a little, it's kind of the same idea where you have a before and after, except that you're just using the tidal volume instead of the rate. So it's the CO2 times the tidal volume before is equal to the CO2 times the tidal volume after. So what you would do here is you select the tidal volume that you want and then calculate for the CO2 that would give you. Let's talk about the addition of dead space and how it affects ventilation. I'm not talking about dead space that's caused by the disease or the anatomic stuff. This is what we call mechanical dead space. And this is typically done in increments of about 50 mLs, which is equivalent of one joint of blue corrugated tubing. And so adding 6 inches of mechanical dead space, which is one joint, generally adds 2 to 3 millimeters of mercury of PaCO2. So what happens here is you can actually change the CO2 while not changing the FiO2. So your oxygenation is going to remain constant, but you're going to actually be able to change the PaCO2. Now, in addition, you need to be concerned about, does the patient have dead space? Now, typically in practice or in this area, we don't deal with dead space a lot. All the dead space that's there is not intended to be therapeutic for ventilation. It's the HME, it's the suction catheter. What we're talking about in this setting at the NBRC is actual additional dead space. And it's there with the intention of altering ventilation, altering the CO2 level. If the problem states that you have dead space in the circuitry, then the thing that you do to adjust it is, the first thing is you remove the dead space before you adjust the tidal volume or respiratory rate. So in the priority of things, it's the dead space, then the respiratory rate, and then the tidal volume. But the dead space there, and they'll point it out if it's there. If they don't point it out, don't read more into it than you need to. But initially, adjust the dead space. Adjusting the tidal volume and the rate. The tidal volume specific to the patient condition, again with a plateau pressure less than 28, although we've been calling it 30, right? Again, that plateau pressure trumps everything. We want to keep it below 30 as much as possible. A patient with normal lungs that has normal compliance, then you might be able to set larger tidal volumes. But in the case of ARDS or acute lung injury, smaller tidal volumes are called for. So this is just the reiteration of adjusting the rate of the apneic patient. And again, the healthier the lungs, the more accurate this equation, but it's before and after type thing, right? This formula predicts what respiratory rate adjustments effects will be on the CO2 level with no change in CO2 production or physiologic dead space. The patient's respiratory rate is 18 breaths per minute, where the CO2 is 50. If a CO2 of 40 were desired, the respiratory rate should be set at what value? And so this is the way you plug that in. The other option here is adjusting the tidal volume. And again, the larger the tidal volume, the lower the CO2, hopefully. But again, if the CO2 production and physiologic dead space don't change, you can use this formula again, just substituting the tidal volume for the respiratory rate, and it's used basically the same way. Sometimes it's a little trickier in SIMV to control the CO2 simply because the patient is able to breathe spontaneously. But what you do here is you set an appropriate tidal volume for the patient, in most cases 6 to 8 milliliters per kilogram. Then you adjust the pressure support to minimize the work of breathing for the spontaneous breaths. In other words, you eliminate accessory muscle use or retractions or any other effort that's involved. And once the appropriate tidal volume and pressure support level are set, use the SIMV rate control to adjust the PaCO2. Now, if you remember, in the assist control, one of the things there is the potential for hyperventilation. And so sometimes it can be tricky here also for adjusting the PaCO2. So you select the appropriate tidal volume based on the patient's ideal body weight and condition. For most patients, again, in the neighborhood of 6 to 8 or 8 to 10. Set the rate to ensure safe minimal level of ventilation. Patient with intact respiratory drive will trigger the ventilator at a rate that sets an appropriate CO2. The patient may hyperventilate by setting a very rapid rate. This may be caused by pain, anxiety, need for suction, etc. Correct the underlying problem. Use sedation and analgesics with care here. In pressure control ventilation, adjusting for CO2. Now, one thing that pressure control offers us that we really haven't discussed yet is it eliminates the issue of dead space, because I don't have to use up my tidal volume now to fill up the dead space. The pressure is what's responsible for inflating the lung, and so if you have a big dead space problem, you probably want to use pressure control ventilation. But the CO2 can be adjusted by the pressure control level or the respiratory rate. Increasing the pressure control level increases the delivered tidal volume, which reduces the PaCO2. Be careful to keep the pressure less than 28. So again, we don't want to approach that 30 because that represents the plateau pressure. Respiratory rate is more often increased to reduce the PaCO2. If the I time is held constant, the tidal volume will be constant. If the I time percentage or the I ratio is held constant, then the I time will decrease, which may decrease the tidal volume, so be careful. Easy to see if the tidal volume has been affected by looking at the graphics package. This is figure 44-18 on page 1125. This is the effects of inspiratory time and inspiratory plateau on a delivered tidal volume in the pressure control mode. Initially, as inspiratory time is increased, tidal volume increases. When an inspiratory plateau is achieved, a further increase in inspiratory time does not result in increased tidal volume. The same effect occurs as inspiratory time is decreased. Initially, with small decreases in inspiratory time, there would be no change in tidal volume as long as an inspiratory plateau was maintained. When the inspiratory time is less than needed for an inspiratory plateau, further decreases in inspiratory time result in a decrease in tidal volume at the same pressure.